Hello, my name is Raekwon Williams. I am completing my field placement at the Shepherd Center, where I follow a team of hospital case managers. The primary focus is to manage clients who have experienced brain and spinal cord related injuries, as well as skin patients. My primary role is to provide support for my clients during their time at the Shepherd Center. I recently received the first patient of my own who I will be working with from admissions to discharge. My patient, DS, is a 64-year-old Caucasian male that resides in the Chamblee area. DS was admitted to Northside Hospital on 1/11 with the chief complaint of left-sided weakness and numbness with facial droop. His primary admissions diagnosis was a stroke. He was then transferred to the Shepherd Center on 1/26 for continued therapy and treatment. Upon meeting DS for the first time, he did not appear to have any cognitive deficits. He answered questions on cue, and his memory recall seemed intact. The only sign of concern that the patient showed was not remembering meeting his case manager, my secondary supervisor, just 1 week prior. This specific case is an interesting one because the patient does not have any insurance. Given his age, a primary concern of mine is determining his eligibility for Medicare and getting his paperwork complete for that process. I have since connected him with our hospital's disability specialist. Another primary concern with this case has to do with the family support that he will receive once relieving the Shepherd Center. DS is planning to discharge back home to his parents in Chamblee. Due to their age, it is already a concern that they will not be fully capable to provide the 24-hour care that he needs. It is also an added stress on the family that DS' father has just been admitted to the hospital. In his hospital chart, his brother and sister are listed as his primary emergency contacts. His siblings do not live in the home with him. They both live approximately 20 to 30 minutes away from his parents' home in Chamblee. The sister has been inaccessible and unable to be contacted during the entire time that the patient has been at the Shepherd Center, but I have been able to keep a steady communication with his brother. The brother was close to the Chamblee area, and from conversing with him, it appears he does not completely understand the extent of care that DS will need upon discharge. Another concern of the family is DS's mental and emotional well-being. The family has expressed concerns that the client is a heavy alcohol abuser, drinking a 6-pack of beer daily, which has caused him to acquire liver disease. In addition, the family expressed that DS has been depressed due to recently becoming widowed. Due to DS not having insurance and less than ideal family support, we are currently at a crossroads in his discharge planning. He has an expected discharge date of 3/26, but the therapists do not believe that he will completely recover by that time. Due to these concerns, the team at Shepherd has organized a conference with DS and his family. According to the neurosurgeon on the team, most patients see the most recovery from stroke within the first 6 months. At this current state, DS requires 25 to 50% for all activities of daily living, which infers that he will need 24/7 care at home. The brother expressed that his aid will be on an on-call type basis. Hence, alternatives must be discussed. Because Shepherd only provides rehab and therapy, their services are viewed as an elective that can only be accessed if there is payer guarantee. The patient arrives to Shepherd on a financial assistance program, but without the cushion of medical insurance, the patient will no longer be able to stay at the hospital. Prior to admission, Shepherd signs a contract with the initial hospital that if payout cannot be guaranteed, the last resort will be for the patient to be readmitted to their initial hospital. Prior to that, the share agreement suggests that the hospital must prove that the discharge will indeed be unsafe, and there must be an attempt to contact a skilled nursing facility for the patient to go to prior to returning home or back to their initial hospital. This is the step that I am currently at for this case. I have to send referrals from Shepherd to these skilled facilities to see if anyone will take the patient without having insurance. So far, we have had no success with finding a facility that will overlook him not having medical insurance. Based on the team meeting, alternate living suggestions outside of the patient's parents' home have been outruled. The patient's brother cannot allow him to live in the residence full time because he is supporting a family of his own with 3 children. And the patient's sister has COVID concerns that have restricted her involvement in his care. Physical and occupational therapy also have concerns that the patient overestimates his abilities following his stroke and fears that this can increase the chance that he falls or harms himself. The patient has reported being able to drive and help with his father's care following discharge, but unfortunately that is not his reality. The patient's brother has expressed that he owns family business in the Chamblee area where the patient is set to discharge, but the team fears that without him being present in the home, that he will be too late. Yes, his poor planning causes him to do harm to himself. Concerns over limited preventative support, family stresses, and patient not having insurance all pose barriers for his discharge planning. Given this scenario, it appears that we'll have to notify the patient as well as his family that he will have to discharge back to Northside Hospital once the 24th arrives. Drawbacks of this choice is that the brother fears that this option will slow Diaz's progression and push it back into a depressed state. But the pro is that Diaz will have the medical care that he needs until the family can sort out their financial situation, and the risk for Diaz hurting himself at home will drop drastically.